Okay, thank you very much for the wonderful skits. We saw a broad range of acting skills and also some very nice strategies. So I like the fact that you thought through the strategies, because we gave you some scripts that are very much based on our own experiences. So these kinds of things are not fictional in the sense that we experienced similar things, and I have a whole shelf load full of these cases. So now we're moving to the last section of the course, which is essentially wrapping up. I'm not going to do a full wrap up, because I think what we did every morning was to recap on the previous session, but just to remind you of some of the core messages really, and then to think about how we move forward in terms of analysis, but then also in terms of dissemination and how to communicate messages. And the exercise that we will be doing as your second assignment, you've already received the task sheet, is a funding pitch. And we thought that this is really an apt kind of assignment for this class, because it's not something often you're trained on how to do. And it is really useful because it might help you in your position secure funding, but it's also something that you should have as a researcher regardless of whether you're going to use this or not. It is the capacity to summarize your research very succinctly. Okay, most of us struggle with that because we go on, we can tell long stories about it, but when people say, what is it you actually do, or what are you actually planning to do, you really want to come out with a very coherent argument. This is why I want to do it, this is what I'm planning to do, and this is how I'm going to do it. So I'm going to give you some tips for that. Okay, we're going to remind ourselves of key features of health policy and systems research. We're going to talk about moving towards analysis, and then moving from the evidence that we have from our studies to action. And the first kinds of actions, we might not be so ambitious as to say that our small study is going to inform policy or practice, but at least we should do a good job of disseminating and communicating at the levels that matter. Once we have thought about our analysis strategies, we then have a body of evidence which we need to think about communicating effectively. And one of the things I'll briefly mention is also the concept of a learning health system. So sometimes the information that is collected in a health systems and policy research project is not necessarily intended for an academic audience or a policy audience, but is intended to feed back into the system. Okay, when you're thinking, for example, about quality improvement research or research that is intended to make a difference to an ongoing initiative, you might try to stimulate health systems research within the system itself so that the data actually feeds back into the initiative at hand. So it's LHS, not LSH. And then we're going to do some tips on producing the funding pitch. So the core messages are, these are nothing new, right? Health systems are complex and adaptive. I think we've emphasized this throughout. We're talking about dynamic interactions, multiple actors, institutions, and power structures. So we look at the health system as a core social institution, but also as an institution that is imbued with power structures. We also talked about the intertwining between the material and the social infrastructure, between the hardware and the software. And by that we mean speaking about looking at the way in which a health system is set up, the very physical space, the offices, the technology that's available, the appointment systems, the digitalization, etc., interacts in complex ways with human software, the skills, the knowledge, the perceptions, the values, etc. The two are not, in terms of how the health systems works, we're always thinking about both, the hardware and the software, right? The other message that we got is we are not just trying to understand what works. We're trying to understand how it works and why it works or why it doesn't work. So we're looking at the dynamics of implementation, the dynamics of governance, okay? Governance being the function of oversight or stewardship, and things like incentives, which are part of governance. The third message that we got from this 9 days is the context matters. We keep repeating that, right? Context is important for everything we're doing. So policies and interventions play out differently in different settings, but even within one setting, the development of particular health system structures or the way people do things can be what is described as path dependent. In other words, they have followed a particular trajectory that is historically determined because of the way the political and historical factors in that country have impacted on the funding available for the health system, the the structure, the political structure, the more democratic versus more centralist versus socialist, etc., and the type of health system and the way in which the funding for the health system happens. The fourth core message is that the system is actor-oriented and that we have a range of health systems actors, both within the system as well as at the interface of the community and the health system, which shape the functioning and the performance of the system. Okay? Now, I'm going to bring back some slides that you'll recognize from the previous lecture, but I want us to remember, I have said previously that all health systems interventions are complex. Because we're not just interested in whether the screening tool works or whether the guideline works, we're interested in why they work and how they work and for whom they work. Yeah? So an intervention is complex because it has a number of interacting components. There are different groups or levels or settings targeted. Often you are not, even if you're introducing an intervention that is intended to benefit frontline workers, it will have a knock-on effect on other workers who are in that system. It's complex because there's usually a number of different kinds of behaviors that are targeted. When you talk about human behavior, it's difficult to compartmentalize and say, I'm only looking at people's learning in terms of their digital literacy. There's a lot more that goes on that is needed to get to the point of digital literacy. Okay? It might be using digital tools. It might be grasping the way in which data can be shown and the way it can be interpreted. So if you break down what digital literacy means, you recognize that there are more behavioral components, some of which may be easier to take up than others. There's always a degree of flexibility in how interventions can be implemented. And that discretionary power that health systems actors have to implement an intervention slightly differently than maybe what was written down on paper, that is also what characterizes a health systems intervention. And there is an intervention between, there is an interaction between the intervention and its context. So we've said context matters. If you're trying to improve a program or a service within a health system, you need a better understanding of what the context is and how it's going to impact on the success of the improvement initiative. Most of our research and practice on healthcare is acontextual. We pretend that the intervention is landing on a blank slate, and we measure its efficiency, its effectiveness, how good it is at delivering individual level outcomes. And in many cases in evaluations of health systems interventions, we think about context either as just, it's sort of there in the framework, we don't really measure it, or we think of it as bias or unwelcome noise. It's often referred to as noise. It's like we need to do away with this because it's not a pure context within which we're assessing the intervention. But that, from the starting point in the health policy and systems research, is, of course, it matters. So it's a critical ingredient, or it's a set of ingredients, and it may be the most important factor in achieving change. Because if you can introduce contextual changes, for example, in the way that the community around your health system, if you can introduce measures which will get them to have more trust in the health system, maybe more people will attend the services that you're trying to improve, and in turn, better trust in the system may result in a higher level of motivation on the part of the health system to actually improve performance. So it may be an important factor. Not understanding it or taking it into account risks wasting money and time. We talked about two types of context. Talked about the external context, the political, the regulatory environment. We mentioned, we had some discussion with Solomon on the macro level. We talked about the role and power of health professionals, and the reason this is deemed an external context is often it is set, right, at an external level. There is a hierarchy of professions. Sometimes that hierarchy is provided in a set of guidelines or an organogram or in terms of people's training, professional training, and sometimes it's cultural. It's the way we attribute higher level status to different types of professionals, and of course also what they represent in terms of their disciplinary background and their gender and whatever other social features matter, and we saw that nicely in some of the skits. The other thing that is important in an external context is, are there any social or ideological movements, such as the movements to provide consumers with more rights or patient rights, or health-related movements, for example, campaigning by patient groups, which have an impact on the way the health system operates. So in one of the skits you saw some ruckus happening outside of the hospital and a relative of someone coming in. Now it could have been just the family who was gathered outside to complain about the state of the care received, or in a different kind of context, it could have been actually a lobby group that is creating pressure on this hospital because they have seen incidents like this happen too often. Another part of the external context is the technological environment. So obviously the availability of therapies, equipment, information technology. So you'll remember we saw that image of a very high-tech surgical ward in Rwanda. And we might be thinking, instead of saying, wow, they've just received all this amazing equipment, if you're a health systems researcher, you should be thinking, is the health system ready for this? Have they got the skills in place? Have they got the health workforce in place? Have they got, constant power supply, whatever, all those issues, the readiness issues, which are in fact operational issues, but they're also around the readiness of the health workforce itself. We also said that you need to consider more carefully the internal context. And often the internal context is something that we look at from a micro level, because we're looking at issues of space, the layout. Is this space a welcoming space where people are going to feel comfortable walking in? We're looking at the diversity of patients, clinicians, and other staff. So in other words, in terms of diversity, if you have I can give you an example. If you have a predominantly a nursing workforce that happens to be dominated by one cultural group or one ethnicity, which is often the case in some countries, where you have most nurses female nurses coming from Kerala, for example, here. In Europe or in the UK, when I had my son, literally all of my care was through a range of professionals from all over the world. So the NHS was bringing in a lot of health workers. And that, of course, also shaped, in a way, the internal context. It has to do with the size, the scope, the scale of tasks that are involved in delivering healthcare. How complicated are the procedures? How many people are involved? The stability of the institution and the kinds of incentives, both economic and non-economic, that it can offer. The standards and values of care. Organizational culture and leadership, we talked about quite a lot. And the relationships, between patients, between carers, healthcare providers, and so on. So we're also interested, I mentioned to you, at understanding that both healthcare workers are also members of the community, but also community members can be caregivers. So in under-resourced contexts, often family caregivers will step in and play vital roles by bringing food, by taking care of patients, the daily kind of cleaning and so on. And again, I remember the scene from Uganda when we were doing the work on infection prevention control. And we noticed that there was a whole area outside of the hospital, an open air area where they had provided some basic covering, where a lot of caregivers had come in and they had literally set up a place where they could stay so they could attend to the pregnant women, because the units were understaffed, and so they relied heavily on the fact that the family caregivers would come in. And there is something called practical wisdom, intuitive knowledge, or ad hoc reasoning. And these are terms that we've discussed in relation to social networks, communities of practice, mind lines. It's the fact that people will have certain ways of working together, and they may form collectives, and they may form ways of communicating with each other, which reinforce a particular knowledge that is shared, and also a particular way of doing things. And they can be quite resistant to change, because there is an assumption that, we've been doing this all these years, this is the way we do things. All right, this is a framework, not a framework so much, but a diagram that you have not yet seen. This is from a paper by Kabir Sheikh and colleagues. And this came out right around the time when systems thinking was coming into mode. I mentioned to you that we went through a series of frameworks, building blocks, control knobs, and so on. And then we reached something that was seen as more people-centered. And moving to a people-centered approach meant that we acknowledged more explicitly the software of the health system. And so here you can see that initially we start with something where policy influences the system's hardware. This is very much sort of encapsulating what the building blocks used to look like. And then we move to something that is acknowledging the complexity of the relationship between the hardware and the software. But then we're also setting that relationship within the broader context. And we're acknowledging that the macro level doesn't just mean macro level policies or guidelines, but it also means the broader national level, international level norms, social norms, medical norms, professional norms, and so on, and the landscape of funding, for example. So we also said that a simple intervention can be complex, and you'll remember this example. Implementing an appointment system. I'll just remind you of what you said. Why is this complex? Anybody? Yep. You're assuming people will arrive, will actually follow, will abide by their appointments. And what else? Yeah, yeah. So what is the technology that's going to be used to inform people of their appointment times? We might even say we would like to know about the space. Are they changing the layout of the waiting room? Are they actually providing more waiting? Because often the situation is that people are crowded along a corridor waiting to get into a room. There might be a few seats, but there's never enough. So it's quite a lot, right? It requires change to the space, possibly, the working culture, and among the patients. Healthcare workers need to be trained on the system of documenting appointments, and you have to ensure that everybody adheres. Okay? Okay, so now moving a little bit more to why are we doing all this? Why is it interesting to do health policy and systems research? And we said that in contrast to clinical research, but also into other forms of research, probably really similar to public health research, it's not just about research, it is about trying to change the system. So your research is aimed at systems transformation. We're trying to understand how systems function and how they can be strengthened. And we're problem driven. We're interdisciplinary and action oriented, okay? I would say that most research is problem driven. Like if you don't have a problem, and that problem can be a knowledge gap, right? But you basically want to ensure that there is a clear problem statement that drives your research. Your goal in health policy and systems research is ideally to inform policies. And the policies can be quite local level. Okay, so you may not be aiming up there, but you may want to make small changes at the systems level. You might want to improve implementation of a particular initiative. Overall, you might want to improve access to the system or quality of the performance. And in a very broad sense, you want to improve systems resilience. So systems resilience means that your health system is better able to cope with everyday shocks, which happen all the time. The extract that you had from South Africa is demonstrating the kinds of everyday small shocks, right? Somebody steals milk money. Some dynamic has happened where so-and-so is in conflict with so-and-so. 2 people are absent. Those are the everyday shocks. Of course, there are bigger shocks that happen. An epidemic, a series of road traffic injuries are going up, or whatever it is, yeah? Or conflict, political conflict, which affects your health workers, but also affects the buildings and the structures. You can't even fathom imagining what happened in Palestine over that period, and how the health system was under shock, under extensive shock over a long period. So thinking about all this, context and complexity obviously has implications for analysis, because you're thinking, okay, how are we going to bring together these masses of data, and how we bring it together coherently in a meaningful way, and especially if I'm using multiple sources of data which may be revealing a different picture, right? Because my survey says one thing, my qualitative interviews with patients say another thing, and my key informant interviews say yet another thing. You've got multiple data types. It's often cross-disciplinary, requiring integration of different kinds of insights. And as we said, this complex adaptive environment makes it difficult to just say X leads to Y. And that takes us back to our conceptual frameworks. That's the reason why we did that conceptual framework, is because I wanted to get you away from the causal thinking, right? Because if anything, the conceptual framework tells you that things are much more intricate, and actually sometimes the small question that shows a number of intervening variables is the more interesting question than the big question. Yeah. So I'm going to talk about just very briefly 3 strategies. The first strategy is simply triangulation, which we're doing generally anyway. Triangulation means you use 2 or more sources for robustness, okay? Because you want not just to compare different views, but you want to, your starting point is that it's a complex puzzle, so I need to capture as many pieces of the puzzle as I can, in the sense that I want to capture those diverse views. It's very different than clinical research, where you don't want so much diversity, because diversity means wrong data entry or something wrong with the data entry, right? If you have a conflict in the data. And here you're actually looking for that conflict. Not necessarily conflict, but you're looking for different views. So triangulation, you are using surveys, for example, and in-depth interviews. That's a triangulation of methods. You're using multiple sources, which is a triangulation of, for example, documents of different types, but also medical records, if you can access them. Or you are talking about investigator triangulation, which means, for example, if you all are working with the same transcripts within your team, you don't want just one person to review those transcripts, but that's also part of the purpose of this course, was to demonstrate the strengths, but also the challenges of working in groups. Yeah? What kinds of discussions arise? What kinds of things need to be resolved? Where do you need to reach consensus? So in analysis, we also talk about triangulation, because we want to reach a consensus in terms of what particular themes are, how we're going to analyze the data, how we're going to come to agreement about what the key messages are in this data. So triangulation is not an analysis method per se, but it is a way of acknowledging the fact that you do have multiple sources of data, and the fact that they present different pictures, different worldviews, has to do with the ontology again, or maybe even the methodology. Because if we say each method implicitly carries assumptions about measurement, then we acknowledge that and we explain that in our analysis. We put that forward and we say, our survey used this construct, this is how we measured it. In the qualitative work, we used a more intuitive, open approach because we wanted to start from people's perspectives. And then you comment on the fact that these two don't necessarily match and why. So that becomes part of your analysis. Sometimes we use something called framework-based analysis, which is you use an existing conceptual framework, or you use your own framework, which gives you, imagine if we were able to boil down, I think that's what you did in your exercise, but imagine you were able to boil down your frameworks even further, because now they're quite detailed. But let's say you boiled it down to a number of key relationships that you think were central to your research questions. So you might say, well, wait a minute, I thought you said conceptual framework comes first, then the questions. You can also do it the other way around. You can say, I do my conceptual framework, I have my research questions, I go back to the conceptual framework, and I now actually look, okay, I've honed it down to 3 questions. So my conceptual framework is essentially around those 3 questions. But some people don't bother with their own conceptual framework. They start with an existing framework, actor network, political economy, and so on, different kinds of frameworks. And they use that to structure their analysis. So in other words, they're using that to identify the key core areas or themes that they want to pick up in the data, regardless of what type of data it is. And it's called framework analysis because it is using a pre-existing conceptualization of the research topic to drive what you're looking for, okay? And I'm going to have to get somebody to remind me, it's inductive, right? You start with a theory, and then you find the data that kind of matches your theoretical assumptions, okay? Another approach is the opposite, whereby it's called grounded theory. We won't talk about it here, but it is deductive, where you look at your data, and then you come up with a conceptual framework. So that would be a different approach. Although it would be also interesting to do this exercise. Imagine if you had done your studies now, and then you went back and you fleshed out your conceptual framework with the actual content. Yeah. So just an example, so you're looking at health workforce shortages, and you could use something called a labor market dynamics framework to integrate your survey data, your policy documents, and your key informant interviews. So I mentioned a PhD student to you who is working on health workforce reform in Guinea, and he is using a labor market dynamics framework, which is analyzing push and pull factors within the labor market. The other thing that we want to briefly mention, simply because it'll ring bells, you already heard about what a realist approach is, what works for whom in what context. And this is an approach to data collection, but also to analysis that specifically recognizes context-dependent effects of interventions. And it uses realist evaluation principles to identify why certain interventions succeed or fail. So again, the analysis from the outset is driven by classifying the data that you have into context, mechanisms, outcomes. So they call it CMOs. You set up a bunch of CMOs, which are mini theories about how mechanisms work in certain contexts to produce certain outcomes. It's quite complex, but it has been done. Okay. So let's say we were trying to understand why mHealth or telemedicine improves access in some rural areas but not others. And we went into an in-depth case study to understand issues of trust, incentives, infrastructure readiness. And we might come up with a number of CMOs, in other words, these statements about context, mechanism, outcomes for this particular initiative, telemedicine. And that would lead us to a kind of realist evaluation approach. Okay, now moving on. As I said, we didn't intend in this course to spend time on analysis because it would be another course of 2 weeks. But just briefly, thinking about what happens next. Yeah, what happens once you have completed your study and you have all this interesting and rich information and you have you have ways of analyzing it, and you've come up with something that you want to now project. So we're talking about dissemination and communication. And they might sound like the same thing, but communication is how you communicate it. It's the channels and the mode, whereas dissemination generally refers to a strategy for transferring your knowledge, for getting your messages heard. So communication is more about the actual mechanism. So you might say, who are we speaking to when we think about Hpsr research? So obviously there's a bunch of different actors there. And it shouldn't be surprising that we're also featuring things like the media there. Because sometimes you really think, if I've got a newspaper which I think is ethically responsible and could be a useful voice for my study, you might need to cater your message to the media, right? Or we're catering it to NGOs who work with specific disadvantaged groups, and therefore you need to package it in a certain way. NGOs speak different language. Lobby groups, another group, okay? But each time you think about the target audience, you're also thinking about a range of things like language, yeah, content, the style of communication, the visual aids, the way you present evidence. You're not going to use the same thing for everybody. So think very carefully when you have a communication or dissemination communication strategy. Don't be over ambitious. Yeah, be very clear who you're going to disseminate to. Most of us as researchers end up doing some amount of dissemination in academic form. Yeah, we do publications or reports. Sometimes we think about, oh, I must somehow bring this research back to my target audience. So I need to go back to the health system and share this in the staff meeting, or I need to go back to my community and share it in a town hall, or whatever you want to do. But think about this carefully. It is more time consuming than you think. And we found that every time we had over-ambitious targets in terms of dissemination and communication, going to make a short film and we're going to do all these infographics and stuff. No, it required a lot more budget. And also it was very difficult to come up with a locally, contextually specific output that was really high quality without spending a lot of time and money. So in subsequent projects, I've learned that do the best you can, but definitely program for some period of time where you think creatively about disseminating and how you will communicate your materials. Okay, at the very least, there should be some way that your research participants get something back in terms of just understanding what happened with this research. And you'd be surprised and amazed how grateful people are for that. Even though I mentioned yesterday that I was horrified at the level of incentivization in some countries. But generally, when you go back to a community and you say, do you remember we did this research 6 months ago? We just wanted to share what happened with it. It's very respectful, and it is very, it's morally a good thing to do, I think. Not easy though, usually you've moved on to the next project, so you have no time. But if you can put that into your budget, if you can put it into your timeline, it is very, very important. So different kinds of stakeholders need different types of evidence. So these are the things you're kind of thinking about. You're thinking about the source, the message, the audience, and the channel. And these all kind of interact, right? So just a few examples. When we think about different kinds of stakeholders, and you will have mapped out your stakeholders already because you followed Solomon's advice and you know how to map actors. Have a strategy. Think about what is it they need from this research. And you might not include all of these, okay, because it's not realistic. But your policymakers, they want something that's clear, that's short, that's punchy. They don't want a long report. Nobody's going to read your 20-page report. 2 pages, max. That's it. They maybe don't even want something on paper anymore. I mean, how many times have I had in the past boxes of policy briefs sitting in the corner that are being used as a whatever else, because there's simply, you don't get to distributing hundreds of policy briefs. So you're going to have to think, especially now in the age of sending people things online, and think about other strategies. Scenario models or high-level summaries. Yeah. If you're thinking about managers, they often want something guidance. Yeah. You say decentralized DRTB policy, there's no good guidelines. So tell us, help us with that. Tell us how to, handle IPC better. Tell us how we can do better in terms of equipping our health workers to be ready for this digitalization initiative. They also love to see numbers. Is this going to make a difference? So with the study on infection prevention control, because we had an economist with us, they were actually able to cost out different kinds of interventions. And this was very popular, that they could see this is the intervention, this is what it would cost, and this is the effect it would bring. Operational reports, toolkits, data summaries, but in a very visible format. Frontline workers want practical insights that have real-world applicability. Training manuals, job aids, sometimes participatory workshops. But again, be careful about the number of workshops you plan in. Many countries are pushing back on the workshops. So I mentioned Uganda, and it's very interesting to note that the health minister, I should share that with you, came on and had a YouTube video, which was really sending a message out to researchers that enough of your capacity building workshops. You're taking our health workers out of the health centers. They are getting used to a custom of having whatever it is, tea, samosas, lunches in some lovely resort for a day. And what's happening with the health center in the meantime? You've taken 30% of our health workers out of the thing. So do your capacity workshops on site. Offer refreshments, but do them where they matter. So it was very powerful. Actually, we were very taken aback, but we thought, she's absolutely right, this lady. I'll see if I can find it for you. So excessive amounts of workshops, first of all, people don't attend. And you also need to put them in places where they will attend and where they will make a difference. Communities, again, we talked about the danger of thinking about communities as somewhere down there, rural, illiterate, etc. No, we're not talking about that. We're talking about, in some ways this could overlap, or in fact, even there. But here we're talking about the kinds of communities that Solomon mentioned in terms of community participation, people who are beneficiaries of the health system, and who might simply need to be empowered to be able to feel trust in the health system, to feel like they're going to get a better service, etc. So there are lots of things around, but more creative, storytelling, community dialogues, new methods that have been evolving, and I think India is actually very advanced in terms of those methods. Okay, so just showing you a few examples. Policy briefs are usually in the range of 2 to 5 pages. These are some from India, Oxfam. This one is enhancing utilization of adolescent health services. So that's what they look like. They're usually a combination of text. These ones are a bit text heavy, I would say. But they have illustrations, they have little graphs, but you really try to make them visually attractive as much as you can. Yeah? So policy briefs and decision maker dialogues. These are a couple of examples. National Health Systems Resource Center in India used policy briefs to translate research on primary care into operational strategies for the Ayushman Bharat centers. Participatory approaches, this idea of co-creating or co-producing, although we said it can be challenging. Can you really do meaningful co-production? But sometimes the co-production is not just with the community. You're also trying to co-create with policymakers themselves, with implementers and communities. So research on urban health in India has used PAR with informal settlement residents. To improve access to services. Okay, a third point I want to talk about is embedding your research findings. Okay, and that is a slightly different idea of a strategy, which is that you think about not the dissemination that goes to the external, but how you can actually disseminate and communicate the research in such a way that it becomes embedded within the environment that you've targeted. So they've talked about real-time dashboards and visualization tools. So can you bring something in that changes the way information is recorded or displayed? So one example is the integrated health information platform, which makes health surveillance data more user-friendly. I'm assuming also initiatives that I'm familiar with in the UK, where you can access your own data nowadays. So those are initiatives that have taken research forward in terms of saying we're going to embed this within the health system. The other thing is thinking about embedded researchers, so embedding researchers within government bodies or health programs to ensure that your evidence feeds into policy in real time. So these are just a couple of points, key strategies to maximize policy influence. Engaging stakeholders early. I've said that you build it into your protocols. Aligning with policy windows. Now you know where that windows expression comes from. It's again from Solomon's lecture, where he mentions policy agenda setting and windows of opportunity, the kingdom streams, right? So you really want to time the communication of your research at a moment, not when it's already happened and everything is, unfortunately, often that's the case, is that our research is completed, but everything has moved on at a much more speedy pace, and therefore it feels outdated. So for example, research that we did on vaccine uptake during COVID, by the time the paper is coming out, which is now, it's not really that interesting anymore. So we've had to rewrite the paper in a way, and also rewrite the kind of communication strategy to say, why is the learning from COVID vaccine uptake relevant to other vaccines, and why is it relevant for pandemic preparedness? We've got to think about how to rejig it. Using intermediaries and networks, so this is the idea of gatekeeper, but gatekeepers at a very high level, policy champions, think tanks, advisory bodies. And this is something we've used in South Africa, is to work very closely with policy think tanks to make sure we get our work fed into there. Frame evidence for action instead of just presenting problems, thinking about solutions and strategies. And this is a bit more challenging. I wouldn't do it, I find it always a bit presumptuous when I see researchers who end their reports with a list of 15 recommendations. I think, well, I'm not so sure about your small 4-month research, whether it really led to that many recommendations. So what I would like to see instead is that the researcher puts a plan in to say, I'm going to take my findings to the people who matter. I'm going to first validate them, whether people find that they resonate with their experience. And then I'm going to reach consensus on what kinds of recommendations we can move forward with. Right, it's a different exercise. It might take a bit more time, but it's more aligned with what is needed. Combining evidence types. I think considering the fact that a policymaker just handing them a brief with scientific evidence might not be enough, but situating it in political context, being aware of the political constraints on implementation, I think is very important. Okay, we said we were going to mention learning health systems, and this is the idea of embedded research. Embedded is the term, i.e. you factor it in. It is, the idea of embed means you think about a plant, right, that is embedded in the soil. So a learning health system, this is a concept that came up, probably the Alliance for Health Policy and Systems Research came out with literature on this probably about 5 years ago. And it's this idea that a healthcare system that adapts and systematically integrates data and experience from research to improve health outcomes is a learning health system. So iterative cycles of research should ideally lead to improvements within the system itself. In low and middle income countries, the implementation of these LHS principles can often address unique challenges, such as the unique resource constraints and the health burdens. But what we're looking at is data, essentially we're looking at using research and evidence in such a way that the decisions are more data-driven. There is a cycle of quality improvement. There's more engagement with people who are actually at the front line, and that you're targeting capacity building initiatives where they will actually make a difference. So in the research that we did in Uganda on infection prevention control, we were specifically studying cycles of epidemic response because we wanted to understand what were people learning each time in terms of infection prevention control and how it could be implemented. So it was essentially intended to feed into this idea of the learning health system. Okay, so we're going to move on to your pitch, which is your assignment. Okay, I think I'm not, as I said, I didn't want to do a whole summary of the course, but I think we covered some of the core concepts. And I'm going to talk you through the assignment a little bit so that if you have any questions, I'm going to devote the afternoon. I will sit with each table for about 20-25 minutes just to hear your individual ideas and to support you in any way you need. Any questions you might have, any thoughts, what is a study design versus what is a methodology, etc., all that. Okay? So in this assignment, the funding pitch, which you'll have already read the brief on, you're going to select an appropriate study design and an approach. You're going to choose a methodological approach that's consistent with the study design and it's aligned with your research question. And you're going to identify some ethical considerations that are specific to your methodological approach. And of course, you're going to pack this into a coherent, convincing, and attractive pitch. Yeah? First thing that we're thinking about is the title. So these are sort of the criteria that we will be assessing you on. Is the title adequately capturing the content of the study? Is it concise? Is it catchy? Okay? I'm going to give you an example. Here's a title. This is from a recent group of students. An exploratory study on the multifaceted challenges and potential strategies for strengthening pharmaceutical supply chains and systems in regions affected by armed conflict, a case study approach. Is it concise and catchy? Shaking your head. No. What's wrong with it? Go ahead, you can critique it all you want. This is not unethical.
Very lengthy.
Very lengthy, yes. And what else? Okay, good. Yeah. Anything else?
There's too much going on in the question. They're trying to address various factors, and as a first-time reader to the question, it's
difficult
confusing.
You're kind of focusing first challenges, but then strategies, but then supply chain, and then armed conflicts. There's too much going on, right? Okay. Too long, too wordy, very difficult to grasp what it actually is saying. It lacks a compelling hook. You see this title, you're already dead by the time the title is read out, right? Overly technical as well. Okay, pharmaceutical supply chain and systems, not quite sure what they mean by that. Okay, another one. Medicines in crisis, strengthening pharma systems in conflict zones. Better, no? Okay. Concise, easy to understand. It's a catchy phrase, medicines in crisis, right? Grabs your attention, communicates the study focus. Now you might say it doesn't describe the type of study, but I think that's okay, yeah? It's basically giving you a very quick idea, what is this about, okay? Now we're looking at problem statement and gap. So the first thing is the title, and the title in a funding pitch is important. I can tell you that because I serve on multiple boards, and usually we're given proposal at the outline stage, which means it's a sort of 4-page brief, and I often get stuck with the title, and I can't help myself. It's a bit like going into a bookshop. How many of us get allured by nice book titles or book covers? And then you read the book and you think, oh, this wasn't worth it. But the title and the cover was nice. It'll look good on my bookshelf, right? I'm joking aside. A title is important because you're trying to grab people's attention. So the statement in the gap, does the problem statement drive the research question, and is the gap clearly stated? So you want to start with a hook, open with a compelling statistic, a question, or it could even be an anecdote that immediately highlights the urgency or relevance of the problem. You want to make the audience care about the issue, okay? Now I know this is culturally different from place to place. In the United States, people use stories a lot and it's very personalized. You know, I was driving along a dust-ridden path and then, you know, this child emerged with X, Y, Z. It's all very overly kind of mushy, gushy sort of stuff. In the UK, they don't like that approach at all. Okay, so you do not start with a big anecdote about you, the heroic researcher savior coming in. Okay, you start, but you still start with something that is going to drive home the importance of the problem. Compelling statistic. In conflict-affected regions, up to 60% of health facilities report stockouts of essential medicines every month. What happens to patients when life-saving drugs are not available? Yeah, statistic and highlighting the problem. Okay. Or you have a thought-provoking question. What does it mean to strengthen a pharmaceutical system in a place where the roads are impassable, the supply chains are broken, and trust in institutions has eroded? Yeah, so that's, without being too mushy or, you know, dragging yourself into it, you're just posing a rhetorical question which highlights the challenge, right? Okay, the next thing is a concise background to the problem. Is it relevant to your statement? Is it topical, and is it succinct? And here it's very, very important to stay clear and focused. You want to provide just enough health policy and systems background to the issue, but not so much general background. So what happens often is that students will get so embroiled in the broader topic, okay? So for example, PPM, TB control, you start to describe the problems of TB in India and, you know, controlling, et cetera, and then I, you know, have to read through 3 pages until I get to the point about the PPM. But your problem is effectiveness of the PPM. So you push that right up front. That is your health systems background. It's not about TB. Yeah? Same thing with introducing a new health cadre. Be careful that you don't get waylaid by all the other issues that the health system is beset by. Your focus is on a health workforce reform, which is introducing a new cadre, okay? And that is your problem, because that is not as seamless as we would hope or expect. You want to avoid jargon, you want to explain the terms really concisely, and you want to keep the pitch tightly aligned with the question. Avoid unnecessary detail. Okay, so remember what makes a good question. This is the next bit. You'll all have a good question, and I'll check your questions this afternoon. Remember that we had these criteria, yeah? What's the purpose or intent of your study? Explore, describe, compare, explain, evaluate. What's the contextual level? Macro, meso, micro. You don't have to mention it in the question. You don't have to say what is happening at the meso level, but be conscious of it in the back of your mind so that your methodology is aligned with that level. What are the concepts or constructs you're looking at? Are they adequately operationalized? So if you're talking about adolescent girls, best to include a bracket. What do you mean by adolescent girls? Yeah? If you're talking about PPM, make sure you spell it out. Yeah? Have you framed the question? So going back to the different ways of framing it, the PICO, the SPICE, the whatever, there are different kinds of ways of framing questions. Is the time frame relevant? Is the setting relevant? Age group, etc. And is the question clear? Can it be answered through the evidence that you can collect and analyze? Because what we will be looking for is that we'll look at the methodological approach and we'll want to make sure that actually what you've said you're going to do is going to be able to answer your question. So what we said, there's one mistake in the slide, which is that in your case, because we did not delve into methods a lot, you do not have to provide a lot of details and methods. So in your task sheet, I've noted that you're going to provide a broad understanding that you might use interviews or document reviews, but you do not have to go into great detail regarding sampling, recruitment strategies, and so on. You really don't have to do that. What you need is a study setting, a study population, a study design, and you can, essentially you can list down some methods, but you don't have to go into a lot of detail. Okay, but is the study setting and the population selected appropriate? Is the methodology chosen aligned? And have you justified why you're using the particular methodological approach? Okay, the last point is the ethical considerations. So I want you to take account of that in your PowerPoint. Are the considerations relevant and specific to the methods chosen and the data they will generate? And please don't just say, we will submit this protocol to the ethics board, because that's not enough. I want you to really be clear about what kind of ethical considerations your particular study aligned with your question raises. Okay? So in the task sheet, you'll see that your pitch has to be very short. In previous courses, we've made it 7 minutes, and you might say, oh, that's so unfair. Why do we only have 5 minutes? But the reason is that there's an expression, I'm sure you have it here too, of the elevator pitch. That if you're really good at this, you should be able to present your study to somebody the length of the time it takes to take an elevator from, I mean, you might say, well, it depends on the building. If I have 26 floors, I have a little bit more time. But instead, what we're talking about elevator pitch, we mean 3 minutes. Yeah? And we often have that kind of exercise in our institutions where we have to do pitches in 3 minutes. I had to do it for my PhD as well. I had to explain what your thesis is about in 2 minutes, essentially. So it really hones the mind is in terms. So we've given you 5 minutes, yeah, but you've got these broad things to cover. Okay, we're going to stop. Yeah, sorry, maybe I should just mention this. This is just preparing the presentation, rehearse it, because it's a PowerPoint recording. You can include yourself as a little, I think PowerPoint allows that, where you can see the presenter. You're going to rehearse it to ensure smooth delivery. You could record yourself. There's a function in PowerPoint where you can record and check the timing. It also does some sort of AI version of checking whether you're sounding very monotonous or whether you're alternating your voice. If you're not super comfortable with speaking English in a presentation, I would just spend a little bit of extra time rehearsing, just for clarity's sake, enunciate each word carefully. I'm sorry about that, but in order for me to mark it, it's going to have to be in English. Present to your peers for feedback. I think that's useful. You'll have some time next week where you actually, no, you won't have time because you won't be here anymore. But I think there might be a way of setting up a little group where you have still some communication after. So I think you should use that. And I think it's useful to have at the end, sometimes it's awkward if a presentation just kind of ends on ethical considerations and then there's like a big thank you, like that was a bit strange. So remember, the last sentence should be, funding pitch, right? For all these reasons, something that says, once again, this deserves your attention because blah, blah, blah. So you might be inviting the audience to imagine the outcomes or changes that your study could facilitate. Succinct and well-timed. You're going to submit a separate list of references, which should be specific and pertinent to the study topic. They can be a mix, but they should have at least, I don't know how many I said, 3 or 5, but you should have some peer-reviewed publications in there, and they should be correctly formatted and complete. Okay. It's a minor point, but it's a good, it's really, again, if you do a funding pitch professionally, it is really important to acknowledge your sources. It's good practice. Okay, good luck. So, as I said, we're going to take this afternoon to spend some time giving you feedback, and we will arrange for the other groups during that time to be looking at an article and thinking about a few discussion questions, just so that you're not, idling. But of course you can start thinking about, your actual, prepare yourself. The first group will not have much time to prepare themselves, but otherwise I think we're okay.